facilities must be available in field hospitals. There should be radiograph capabilities. There should be operating rooms, vital signs monitors, sterilizing equipment, blood bank, ventilator, basic laboratory facilities. What are the functions that are performed in field hospitals? 3 main functions. First aid in form of suturing cuts and lacerations, splinting simple fracture, and then review at local hospital. This is first function. Second function is emergency care for life-threatening injuries. For example, putting endotracheal tube, tracheostomy, doing a tracheostomy, relieving tension pneumothorax, stopping external hemorrhage, relieving an extradural hematoma, emergency thoracotomy laparotomy for internal hemorrhage. And then after damage control surgery, transfer patient to base hospital once stable. The third function of field hospitals is initial care for non-life-threatening injuries. For example, debridement of contaminated wound, reduction of fractures and dislocation, application of external fixators, vascular repair, and then transfer patient to base hospitals for definitive management. Be aware that, and keep in your mind that, reimplantation of amputated limbs and extensive reconstructive procedures should not be attempted in field hospitals, as they are time-consuming. Let us now talk about some specific issues that concern the disasters. There is a special type of surgery usually applied in disaster surgery called damage control surgery. What is the definition of damage control of surgery? It is the minimum amount of surgery should be performed to allow safe transfer of patient to definitive treatment facilities. That means the principle of damage control surgery is ensuring the airway, control bleeding, compartment are decompressed, prevent contamination from developing into infection, take actions which prevent deterioration during transfer. يعني باختصار damage control surgery أسوي أقل سيرجري ممكن للحفاظ على حياة البيشنت إلى حين نقله. يعني مثلا سويت لابراتومي لقيت شاترد ليفر، بدل ما أجي أسوي لوبكتومي أو أسوي سيجمنتكتومي، أسوي باكينج، أخلي باك بس أوقف لي. ونفس الشيء إذا لقيت مثل بيرفكت فراكشر، بدل ما أسوي extensive procedure of fixation fracture and like that, we just apply back to stop the bleeding. And other procedures, we do the minimum of that procedure that is essential to keep the patient alive and preserve the life of the patient, depending on these mentioned principles. Control bleeding include, we may do by damage control surgery, we may do laparotomy, thoracotomy, repair of major vessels, and also in compartment decompression, I may do burr hole, chest drain, laparotomy, fasciectomy, and like that. Another important issue in disaster surgery is the wound debridement. Wound debridement. Debridement is also French term mean to unleash or cut open، يعني نعوف الجرح مفتوح، فتح الجرح هو بالحقيقة. Debridement plays a crucial part in the management of trauma. Wound disasters are often heavily contaminated, containing foreign bodies and non-viable tissue. Aim of the debridement is to reduce the chances of anaerobic and necrotizing infection and can prevent systemic sepsis. What are the principles of debridement and initial wound care? Ideally, debridement should be done under general anesthesia, but we can do it under other types. But this is the ideal way to do debridement. Also, we should obtain generous exposure through skin and fascia. We can elongate the wound, lengthening the wound or take new wounds, and we have by this wound we have to get full exposure of the injured area. Also, we have to control the bleeding and identify neurovascular bundles. We should excise all devitalized tissue. Keep in your mind that we should excise from the skin the minimum just to reach the edge of bleeding. While from the muscle, as they say, cut to hustle. Be generous in cutting the muscle till you reach the point of bleedings in the muscle. Also, you should remove the foreign bodies, repair major vessels. You should obtain skeletal stabilization with external fixator. That means if there is any fracture in the limb, you should fixate it by external fixation in order to not allow this fracture to injure the vessels or disrupt the repaired vessels. Only tag tendon and nerves that have been cut. In disaster surgery, where there are too many injuries, you haven't enough time to repair the tendons and nerves. Just tag them. تخلي علامة عليهم حتى بعدين بالبيس hospital we can do the definitive repair. Leave the wound open and delay primary closure. This is essential. We have to keep the wound open. Good saline wash irrigation is better than betadine hydrogen peroxide wash. Also, you should keep this in your mind. Avoid tight dressing and elevate the injured limb. These are the principles of debridement. Another important issue in disaster surgery is the compartment syndrome. Compartment syndrome is common in calf and forearm. When there is closed injuries cause hematoma leading to increased pressure in that compartment. It is often associated with the fracture of the underlying bone, which in turn, this increase in pressure compress the blood vessels and cause ischemia with features of ischemia which are pallor, pulselessness, pain, paresthesia, diffuse swelling, and coldness. If this allowed to progress, it may lead to renal failure, infection, septicemia, and abscess formation, gangrene of the limb, chronic ischemic contracture, and disablement. The clinical features of compartment syndrome include severe pain in the leg, sensory disturbances, color changes. Also, you should be aware that absence of pulse is a late sign. Also, affected muscles, when passively stretched, worsen the pain. That means pain on passive dorsiflexion of the foot may be initiated, and this is the most reliable clinical sign. Pain on passive dorsiflexion of the foot and the calf muscle. This is the most reliable clinical sign. Also, the most prone site for compartment syndrome is the anterior compartment. Also, we have to measure the pressure in that compartment by using pressure transducer. And when the compartmental pressure is greater than 30 milligram mercury, is an indication for urgent fasciotomy. What is the treatment of compartment syndrome? Is by doing fasciotomy. Infection and amputation are frequent outcomes. Also, put in your mind that the danger lies in the delay of treatment of compartment syndrome, not in the simple fasciotomy. In crush injuries who present late to hospital, it is safer to do amputation, not to do fasciotomy, because may lead to crush syndrome and renal failure. Let us also talk about important issue in disaster surgery, which is a crush injury. Crush injury occurs when a part of the body is being squeezed or compressed between two high forces or a pressure system. It causes extensive laceration, bruising, compartment syndrome, crush syndrome, hemorrhage with extensive tissue destruction and devitalization. This will lead to renal failure, hypovolemic shock, and sepsis. These are the most dreadful problems. نتيجة الكراش injury may lead to crash syndrome. So what is a crash syndrome? It is due to crushing of muscle, causing extravasation of muscle and release of myoglobin into circulation, leading to acute tubular necrosis and acute renal failure. فالimportant هنا يصير release of myoglobin from the muscle into circulation. It will obstruct the glomeruli, the tubules, and cause acute renal failure. What is the main causes of crash syndrome? That occur during earthquakes, mining and industrial injuries, air crashes, حوادث طائرات, when applying tourniquet. Sometime after applying of tourniquet for a long time, this will lead to crash syndrome. In crash syndrome, there is initially tension is increased in muscle compartment, commonly in limb, which itself impede the circulation and increase the ischemic changes. In 3 days, urine become discolored and scanty. Patients become restless, apathy, and delirious with onset of uremia. Crash syndrome is often life-threatening injury. Is much worse than initial look. What is the effect of crash syndrome? As I said, renal failure, toxemia, septicemia, disability with extensive tissue loss, and gas gangrene. What is the treatment of crash syndrome? First, you should be aware of associated injuries. There may be other injuries like splenic rupture, liver laceration, extradural hematoma. Also, the main line of treatment is aggressive volume loading of the patient. That means give IV fluid. We should give generous IV fluid. We should give about 1,000 to 1,500 cc of saline every hour till there is no myoglobin in urine. And also we have to give diuretics like mannitol or riomacrodex. Also we should do alkalinization of urine by giving sodium citrate or sodium bicarbonate, because alkaline urine cause dissolution of acid hematine and aid in excretion of myoglobin. In crash syndrome, we have to do late fasciotomy. That means we should do these measures, the aforementioned measures, before doing fasciotomy. After there is no myoglobin, we can't do fasciotomy, late fasciotomy, because if we do early fasciotomy, this may aggravate the situation. There will be release of much myoglobin from the muscle and become irreversible. It is therefore best not to perform fasciotomy in cases where entrapment has been for over 12 hours.